Hi, welcome to Brigham and Women's Hospital. My name is Rachel Ashby and I'm the Medical Director of the Donor Egg Program. First, on behalf of the entire team, let me thank you for your participation in this process. Your role is critical in helping families realize their goals of parenting. Today is going to be a busy day for you. You will first view this video and undergo educational training with our donor egg team. You will also be seen by one of the IVF physicians, where you will have the opportunity to undergo counseling regarding this process, as well as answer all questions. Please note that there are no unimportant questions in this process, and the doctors are here to entertain questions about the IVF cycle, as well as any future ramifications. You will also be seen by a social worker today. So again, welcome to the Center for Reproductive Medicine, and thank you for your participation.
Hi, ladies. Welcome to the Center for Reproductive Medicine. My name is Joan Eilers, and I'm one of the donor egg coordinator nurses, and I want to thank you for coming in today. I'm going to be presenting today your class on donor egg therapy and doing a donor egg cycle here with us. And I want everybody to be comfortable and relaxed. You should have some paperwork in front of you, but we're going to just take our time, walk through everything, and then at the end there'll be time for questions. There'll be a live human at the end for questions. Okay, so first and foremost, thank you so much for attending. We are very grateful for your coming in today. This is a very exciting technology that we're offering to you and to our recipient patients. Our recipients also want to thank you for coming in today. It's a big adventure to come on in, learn about this technology, and be willing to take time out of your busy day and your school schedules. Becoming a patient at Brigham and Women's Hospital, two reasons that you're here today. The first is for you to become a patient of us here, and by doing that, you are entitled to the same rights and privileges as your recipient. So what that basically means is that you come in and you're here, you're going to be seeing your physician, a social worker, taking this class as you're doing now. You are going to have infectious disease blood work drawn. You're going to learn how to do injections, your favorite part. And by doing all of this, you become our patient, just like your recipients are our patient. The second reason that you're here today is because we need to be able to get a sense of you and evaluate you, both for your physical capability to come through as an egg donor in our program, and also your emotional and logistical ability to come through. Your recipients are obviously very vested in that, and they have a lot of hopes and wishes based on you and your agreement to go through this process. So it's our job to work with you to get to that end. I'd like to do, just a little class overview. We're going to talk about all the medications that you'll be taking. There's basically 3 major medications that you'll be taking for this process. We'll be talking about monitoring, that is testing while you're in cycle. And we'll be talking about the actual egg retrieval. And there's a lot to discuss about all of it, but we'll get to everything as we move along. Housekeeping process for today, we're here to help you move through your day. Some of you will have seen your doctor this morning already and are sitting and having this class today. Others of you, this is the first appointment of your day, and you'll be seeing the social worker and some of your other appointments as you move on through. So we're here to help you get through your day. It's important to keep your class schedule. Follow your appointment schedule as you move through the day. You have a written copy of your appointments for the day, but I just want you to realize that as you finish and complete each appointment today, you will need to check back in with the secretary in the waiting room at the Center for Reproductive Medicine after each appointment. There are many patients coming into the center, as you'll see, as you move through the day. And we don't want to lose you in and amongst our day. You really have to sort of say, hey, I'm here, and waiting for whoever it is you're waiting for as your next appointment. You'll sit down today with me or with one other nurse, my colleague Nancy, or maybe even another nurse, to go over the specific things for your cycle. We'll be going over cycle instructions with you, which will be a written instruction sheet describing your medical regimen. We'll be signing consents for all your procedures, and we'll be doing that injection teaching that I know you're really looking forward to, and I promise we'll get you through it. It's what we do, and we do it all the time, and you will survive. I promise that. Okay, if you all want to pick up your red folders now, that would be terrific. Red folder, everybody should have one. You have a whole bunch of papers in this red folder, and I just want to go over what's in there so you'll understand what you have. This is the booklet for going through an IVF cycle here at the Brigham. This booklet has everything that I really talk about today, and it has diagrams, which is fabulous. Diagrams of where to go and how to do your monitoring and different sites to use, and monitoring for medication administration, and we'll skip that for now. And pretty much everything I talk about is repeated in here, so it's an important thing to keep handy and to remind you as you go along, okay? The other piece of information important in here is, let's see, it's the sign-in sheet. This is a sheet that you'll be completing every single time you come in for your monitoring. So when you come in for blood work or vaginal ultrasound, you'll complete one of these sign-in sheets. I'll talk about it later in the lecture, but important document. It gives your nurse, your cycle team nurse, the heads up every time you come in so we can track you and look for your results and then get back to you later in the day. So that's an important piece of paper. Also, you'll have some pharmacy information in your packets, which you can just review through. Then the other two documents, this one is your standing order sheet for blood work that you'll have drawn during your cycle. You'll have a variety of different blood tests drawn, and we'll give you the lingo for those later in the lecture. But this, when you've come in for your very first visit to have your blood work drawn, which would actually for you guys be the baseline appointment, this piece of paper you're going to be giving over the very first time. The lab staff is going to take the first two copies. If you notice, there's 3 copies attached. The lab will take the first 2 copies, rip those off. They'll keep them for their purposes every time you come in and test. And you're going to keep this last pink copy, okay, for your own purposes. You can make notes on this. You can actually write down the dates that you come in for testing. So you'll have a little log of like what you're doing and where you're supposed to be in cycle. So this is an important sheet. The other sheet is for ultrasounds. This is for vaginal ultrasounds that you'll have done at almost every single monitoring visit that you come in for. You'll notice there's a bunch of these in your packet. You're using one of these every time you come in, all right? So remember, this is your standing sheet, which you're using only once because the lab will be keeping a copy of that. You'll have your copy just in case. And the ultrasound sheet, you'll use every time a different requisition. So let's see, what else is in your packet? I think that's pretty much it. The other, I guess, important thing to note about your packet is that every single time you come in, this packet should come with you with your blue hospital card, which is located on the inside flap of the packet. You want to bring that every time. So in case you lose something or you forget something or you don't remember where you're going or where you're supposed to be, this packet will tell you that each time. I did forget one thing. The Fda Questionnaire that's located in your packet, that will actually be completed today. You'll notice that a lot of those questions are similar to what either I or Nancy, my nursing colleague, asked you during your phone interview. And so we just have to have you sign off on those questions today. And just another thing the government wants us to do. I know, more paperwork. So that's the paperwork, housekeeping. So you can all sort of take a breath. And now let's just sort of do an overview of what is IVF, exactly what is it that we're talking about here today. In vitro fertilization is what IVF stands for. In a nutshell, it's the process where we stimulate your ovaries to produce more than one egg. In a normal cycle, monthly, you produce 1 egg. In this process, we're hoping to get your ovaries to produce more than 1 egg. In your case, as an egg donor, you'll be producing hopefully about 12 eggs is what we're looking for, and we'll talk more about that. We're going to be removing the eggs in the process of an egg retrieval. We're going to be mixing the eggs with your recipient's partner's sperm in the laboratory, the embryology lab, and then we're going to be incubating those eggs as they form into embryos in the lab for a few days after your egg retrieval, and then returning those fertilized embryos to the uterus of your recipient. So that's in a nutshell what the process is about. The actual cycle itself, I'm going to skip ahead here. The actual cycle, you guys are probably thinking, how long is this going to take? This sounds involved. The actual time frame that you're taking the medications is a 1-month time frame. This is the period of time from when you begin injectable medications until the egg retrieval is achieved. However, we do consider the month before your IVF cycle to be sort of part of the cycle in that you're preparing. We're going to be putting you, if you're not already on oral birth control pills, we're going to be putting you on those with the period before the donation. We're also going to be asking you to use barrier contraception, condoms, with that period. So the month before, you're gearing up with active birth control pills and with barrier contraception. We'll talk more about that as well. This is sort of an overview of the medications, just to review things. First category of medications, suppression therapy. We begin to suppress your ovaries when we give you the oral birth control pills. Some of you might be on the Ortho-Evra patch. That's okay too. We use that here as well. Most donors just happen to be on the oral pill, however. So that's our first suppression therapy. Lupron is the second suppression therapy, which is a injectable medication that you'll be taking daily throughout the cycle. Then, once we've achieved a certain level of the suppression, we will be giving you some stimulation medication, also known as fertility medication or super fertility medication. These are the medications that gear up your ovaries to produce more than 1 egg. The two medications we generally use for donors are Gonal-F and Falston. One or the other would be what we'd be using with you. Then the last category of medications are the medications that prepare you for the actual egg retrieval. The first one is called Hcg, and that is also known as Hcg Chorionic Gonadotropin. That is also referred to as a trigger medication. You'll get used to our lingo as we go along. And we also use an oral antibiotic the night of your egg retrieval, just on a very rare chance of infection. The egg retrieval is performed under super sterile environment, but we like to be triple sure here that there's no possibility of infection for you. Okay, let's see. So let's talk a little bit more detailed about the suppression medications. Oral contraceptive, OCP, also birth control pill. We're going to have you start the pill pack within the first within the first 3 days of your period. Well, what does that mean? Well, the first day of your period is the first day of full flow of your period. We count that as day 1 of your period. We will be advising you to start your pill within days 1, 2, or 3. So cycle days 1, 2, or 3. The purpose of the birth control pill is to inhibit these 2 hormones that are naturally being produced in your body. One is the luteinizing hormone, the other is the follicular stimulating hormone. The pills, if you're using them for your own contraceptive purposes, will regulate your cycle and inhibit ovulation so that you would not become pregnant. We're using them pretty much for that purpose here, but we also use it for the purpose of synchronizing you with your recipient. At some point in taking your birth control pills, we're going to be moving you to a status of active pills only. What that means, is that the first 3 weeks of your pill pack are active pills. Then you'll have a week of pills that are sugar pills, placebos, or we might order for you a pack of pills with no 4th week of pills. That's the time when you would normally have your period. When you're gearing up and you're synchronized with your recipient, we're going to have you take your 3 weeks of active pills, skip that week of placebos, and go right into a new pack of active pills. That's going to erase your period of the good news, and it's going to keep you synchronized and help us manipulate your menstrual cycle into your recipient. But we'll let you know when that's going to happen. Side effects. Some people feel some early pregnancy symptoms, some fatigue, slight weight gain, but you're not on them long, and breakthrough bleeding. And that actually we see a fair amount in donors. You'll feel as if you'll call and say, gee, I think I'm getting my period, and actually it's your body trying to have a period, but us not letting it do so with taking your pill. Let's see. Lupron. Lupron is the second suppression medication. This is a small needle injectable medication. It also suppresses the natural hormones you're producing, luteinizing hormone, FSH hormone, estrogen, and progesterone. It's going to additionally stop you from ovulating, and it also actually helps give a better quality of egg. Lupron is a once daily injection. Well, what that basically means, you're going to really love this part. You're taking Lupron between 5 and 7 in the morning. I know, between 5 and 7 a.m. Now, what we want you to do is to take the Lupron at a specific time each day. So we don't want you taking it sometimes at 5, even though I know most of you won't be awake at 5, but we want you to take it probably closer to 7 so you can, woohoo, sleep till 7:30 on the weekend. So stick within 30 minutes of your administration time. Very important. Small needle injection. Did I mention that? I think I did. Side effects. Hot flashes, insomnia, headache. Most donors, most young ladies in your age category don't have a lot of side effects from Lupron. Occasionally a donor will complain of a headache. Mild headaches that can be relieved with Tylenol. We'll get to that. Use of condoms, extremely important. We use Lupron off-label. And what that basically means is that the FDA, when Lupron was produced 25 years ago, wanted us in the medical community to use it for patients with prostate cancer, brain cancer. This is to suppress the cancer cells from growing. We're using it to suppress your ovaries from ovulating. The important thing to note about Lupron is because we're using it off-label, if you were to become spontaneously pregnant on your own, in other words, you're having intercourse, you're not using condoms, we don't know the effect of Lupron on a fetus. So it's important for you to use condoms. Preferably, we'd really rather you would abstain from intercourse while you're going through this process because you're super fertile when you're taking these stimulation medications later. So abstinence is actually the best policy. If you find yourself in a situation where that's not going to fly, please use condoms. It's important. Sometimes, very rarely, a local reaction to the Lupron, a little bit of local redness, usually not too much of a problem. Okay, I'm actually going to go back a slide. I just want to show you what Lupron looks like, and I'm going to just step over here and grab my box of Lupron, just so you'll be familiar with the medication when you receive it. Lupron is also known as Lupralide Acetate, and it comes in a box like this. This is actually a 2-week supply of Lupron. You will only need 1 box of this, believe it or not, because you only take it in very small amounts, tiny, tiny amounts. So this is what will be contained in your Lupron, in your larger package of medications. So your Lupron, in your packet, what you'll find is everything you need to administer Lupron. You'll have your small needle injections, which is an orange cap syringe, the only syringe that you should use to administer Lupron to yourself. Quite a lot of alcohol wipes, okay, to cleanse your skin. And then the actual Lupron is located in this little bottle. And I'm going to actually open this and show you it. No, the only thing to sort of keep in the back of your mind about Lupron is if you are going through the cycle in the summer months and you don't have air conditioning in your house, Lupron needs to be stored below 77 degrees. So it's important to know that. You can put Lupron in the refrigerator, but never the freezer. Okay, that would be a bad thing if you tried to do that. Okay, so Lupron comes in this little box, and it looks pretty much like water in a bottle. Okay, when you first open this Lupron, when you first take the medication out, you flip a little cap off the top that doesn't go back on, so you're not going to be putting that back on later. You'll notice there's a rubber stopper in the top of the Lupron bottle. And that's because there's so much medication in here, you're actually going to be you'll be going into this vacuum-sealed top many times, once a day, to get your medication dose out. So what I'd like to do now is just show you quickly how to draw that up so you can see it, so it won't be too alarming when you first do it. Okay, so here's your Lupron bottle. You're opening one of your alcohol wipes, okay, and you're cleaning off the top of the bottle. Of course, before you've proceeded, washing hands. Every time you're going to give yourself a medication, you're washing your hands. Okay, I'm going to sneak into my box here. There we go. This is your orange cap syringe, okay? Same syringe that a diabetic uses to give themselves insulin. So it has to be easy because, as you know, diabetic, if you have anyone in your life who's diabetic, they actually have to give themselves insulin a number of times a day. So we're taking this out. The syringes come, they come in units, not to be confused with any other measurement units. There'll be either 50-unit capacity in the syringes you receive from the pharmacy, or sometimes it's a 30-unit capacity. And the calibrations might look different, but it just depends on the syringes from which manufacturer they come. When you first take your cap off, be careful because it can stick on. And basically, you're pulling your plunger of the syringe back. Almost all of you, although don't count on this, many of you, let's say, will be giving yourselves 10 units of Lupron a day. In order to get medication out of a vacuum-sealed container, you need to put air, air into the container. So what you're doing after you've wiped off with alcohol is you're inserting the needle into the rubber stopper, pushing your air in, then you're flipping the bottle over, and slowly withdrawing the plunger, pulling the medication back. In this case, I'm pulling back to 10 units. Okay? You can pull back a little bit further. Sometimes if there's an air bubble in the bottle, just by pushing back up to the dose, you'll get to where you need to be. The top of the plunger is what you want lined up to the mark of the units that you'll be receiving. So in other words, here I'm coming up to 10 units. Now I'm done. I'm going to take my needle and syringe rather, out. I'm going to be giving a little flick with my finger to let any air bubbles rise up out of the needle. Remember, air bubbles can hurt you. People say, air, oh my gosh, I'm going to inject myself with air and something bad's going to happen. It's actually not going to happen. You would need to have volumes of air in order to hurt yourself. What we're looking for is to get the air bubbles up and out so that you have enough of the actual dose. The air can displace the medication, and that can be a problem, okay? So there we are. So now I'm ready. I'm going to loosely recap my syringe, and I'll talk later about where our injection sites. But that's basically what it's going to look like to prepare your Lupron dose, okay? All right. We'll put that away for now, that part of our show and tell. There's more show and tell coming up. Let's see. Okay, stimulation medications. These are the fertility medications that we talked about a little bit earlier. Gonal-F, Falston, rarely Repronex. Repronex is not something most of our donors need, so you probably won't have to worry about that. Repronex, I will just make one small note about Repronex in that if you do have to, if you're ordered for Repronex, that can actually only be administered in the abdominal area. We'll talk about sites later for administration. Stimulation medications, again, we're looking to stimulate your ovaries to produce a minimum of 12 follicles. Well, what the heck's a follicle? I thought she was talking about eggs. Follicles are the fluid-filled sacs that contain the egg or eggs, okay? The We practice here in a very conservative way at Brigham and Women's. This is a Harvard-affiliated institution. And so our goal here is to produce just enough eggs to get you where you're going. It's not our goal to produce 30 or 40 or more eggs. Some people respond that way. Some donors do respond very aggressively to the medications. But we try to give you just enough medications to produce the 12. Most donors produce somewhere between 12 and 20, probably closer to 20 follicles. The stimulation medication is also a once-daily medication injection, and that is actually taken between 6 and 9 p.m. Also, small needle injection. Side effects, mood swings. Not many of you know a whole lot about premenstrual syndrome. Sometimes I'm talking to my donors and they say, oh my goodness, I don't have that. Is that something I should worry about? Most of us women don't really get into premenstrual syndrome until we're closer to our 30s and 40s. But basically, if you've been around an older woman, like your mother, for instance, and she's been very moody and very emotional, crying at the drop of a hat, that's what premenstrual syndrome is like. And you may experience some of that on these medications. Some people don't. Most people do. So you might want to not make any major decisions while this is going on. Ovarian hyperstimulation syndrome is also known as OHSS. This can be a complication that we're going to actually talk about a little bit further. Most of you will experience a mild effect of the medications that will cause you to feel somewhat bloated with some fluid gain before retrieval and shortly after retrieval. But it's a fluid retention thing, and it's not permanent weight gain, so it will go down. But you'll feel that way because these follicles are growing and they're fluid-filled sacs. So you want to wear loose clothing when you're coming in for your egg retrieval because you will feel a little bit of that bloated kind of feeling. Again, though, temporary. Medication mixing, we're sort of walking our way through this, small needle injection, and then later, just when you're really used to the injection piece, we do have one intramuscular injection that you do need to self-administer or have a friend or family member come in and learn how to give to you. And that's at the very end of the cycle. That's our Hcg medication. We'll be talking about that. Okay, I'm going to back up a second. I just would like to go over with you the stimulation medications, show you what they look like, and also how we draw them up. Okay, well, I'd like to start with the Falston pen. Okay, this is a great gadget. Many of you will be ordered this medication. Some of you will be ordered the Gonal-F medication. Actually, believe it or not, which drug we order for you is which drug we order for you is actually related to your recipient's insurance, and so we actually don't get to choose that, which one. But nonetheless, Falston pen. This is what will be contained within the Falston pen packet that you'll get. You'll open this up, and it's a pen device that you'll actually be able to use over and over again, if I can get it out of the packet here. Okay, so this is our pen. In here you'll also find the actual medication in a cartridge. There'll be at least 2 cartridges in your container. And then these are the little tiny subcutaneous needles that you use to inject. There'll be a whole bunch of those. You use 1 needle every time you give yourself an injection. Okay, so we're starting with our pen. This is our Falston pen device. Take the cap off, and you can unscrew the device like this. Then you'll be inserting your cartridge. It slips right in. And then you screw the cartridge in. There we go. Okay, and there you go. You're loaded. Then you're putting on your needle, one of these little small white capped devices, and that's going to screw right on. Okay? There you go. What's fabulous about this medication is that it comes in a dial-up form. So this Falston comes in international units. So what that means is instead of saying units like we had for Lupron, this is IUs. You're going to dial to your dose. You're turning the wheel toward yourself. And it's coming in clicks. So for instance, I'm coming up here and I'm clicking at 225 international units. I've clicked to where I need to be. I want that dose to be right in the middle of this little tiny window. Once it's in the middle of that window, I'm ready to inject. Now let's say I needed 225 international units, but I went past by accident. I slipped. I'm going to go all the way to the end, dialing all the way to the very end. I'm going to come back, if I can, click, and I'm at 0. That's the way if you make a mistake. Okay? Now, ready to inject. I've washed my hands before I've started. I'm going to clean my skin with alcohol wipe. And here's the outer cap, inner cap. It's actually a needle just about the same size as the Lupron. It's a little bit longer, but it's just as fine. Okay. That's our Falston pen. And now I'd like to show you the Gonal-F, in case that's what's ordered for you. Okay. This is the Gonal-F. This is how it comes. This also comes in international units, just like the Falston, but this comes in 75 international unit ampules. You're opening your box. You'll actually, if you're on this medication, you'll have a ton of these boxes that you'll receive, a lot of these. Most of you will be ordered for at least 2 of these a day, so 150 international units. Each box has a number of different things in it, and I'm actually going to show you them. You've got your medication, Gonal-F, 75 international units, in powder form. This is empty, but it would normally have a little white powder in here. Also contained in your box is a sterile water diluent. This is to dissolve your medication. 2 needles, 1 long needle for mixing the medication, the water into the powder, and also drawing up. And then at the end, you're going to be switching to a small injectable needle, subcutaneous. What you're doing here, taking your cap off your diluent, putting on your large needle. Whoops. Well, maybe not. There it is. Remember, this isn't going into your body. A little bit of suction there. There we go. Alcohol wiping off the top of the bottle. You're injecting your needle into the vacuum seal, injecting your water, turning upside down, just like we did with our Lupron, slowly drawing back everything inside the bottle. The powder actually dissolves very, very quickly. Once the water, the diluent comes into contact with the powder, it dissolves very quickly. You're drawing this up. You're getting each last little drop, which means you have to pull your needle back. You're doing the same flick to get any air bubbles out. If there's an air bubble at the top, you can sort of push your plunger up. Usually a little bit of air in the needle anyhow. Now we're going to recap, because remember, we're not using this large needle. Recapping, and we're putting on our smaller needle. Well, maybe not. Let's see. I can't show you the smaller needle, I'm afraid, because the suction is too great on this. Oh, there we go. I was wrong. Okay, small needle injection, same principle. Okay, ready to go. All right, so that's going to be it for our stimulation medications. And remember, we're available after class to answer all your questions about this. Okay. Hcg medication, human chorionic gonadotropin. This is also known as Pregnel or Novarel. What happens is that when we order your medications from our mail-order pharmacy, we're never sure which Hcg they'll be sending you. That's why I like to, not to confuse you, but that's why I like to tell you that the Hcg box may say Hcg, it may say Pregnel with Hcg underneath it, or Novarel with Hcg underneath it. And I share that so you don't get confused. It get a little stressful. When you're getting ready to prepare your HCG, I want you to open the book that's in your red folder, because it'll be far down the line in cycle, and you'll need to open that up and remind yourself how to do all this. Hcg is responsible for the final maturing of the eggs. It's also known as your trigger medication. It's used to induce ovulation. We're giving it to you 36 hours before your egg retrieval. At that time, we'll be telling you to discontinue your Lupron, discontinue your stimulation medication, and get ready to take your Hcg medication that night. We will not be having you give your Hcg medication until your estradiol level reaches at least 600, and you have a minimum of 2 follicles that measure 18 by 18 millimeters. Most of you will have many more follicles than that. The risk is early ovulation of HCG or ovarian hyperstimulation syndrome, also putting more fluid on board, and other of the possible complications. Most people don't get into a problem with that. We'll talk about that. I'm going to add this as a note. New federal guidelines, the FDA forms that you're filling out today, they are effective May of 2005. We will be repeating your infectious disease screening within 30 days of your egg retrieval. Basically, you'll all have your infectious disease screening today, but we'll repeat it one more time while you're in cycle, probably around the time of your baseline testing. If you do monitor here at the Brigham and you choose to come here for all your testing during cycle, we will schedule your infectious disease testing at one of your already scheduled monitoring appointments. If you are a satellite patient, in other words, if you're monitoring at a hospital outside of the Brigham, we will have you come in on a separate appointment. There will be an extra visit to come in for the blood draw and the cervical cultures. I just want to go back to HCG for a moment, and I just want to do a little show and tell for you and show you what the Hcg box will probably look like. Okay, this is our Hcg, Chorionic Gonadotropin. It actually comes with 2 bottles in the box. One is the actual Hcg medication, which comes in a bottle just like this, only it's powder form. Okay, this is actually diluted already, so this is just for purposes of the visual. The Hcg will be powder. You will also have in there a bottle of diluent. This is the sterile water that you're going to use to make the powder into reconstituted medication. For this purpose, we'll be giving you a couple of 3 cc or 3 milliliter syringes. Milliliters and cc's are interchangeable doses. I just don't want you to get mixed up. Milliliter and cc are the same. 3 milliliter syringe used for the Hcg. There'll be a few of these, even though you're only doing this medication once. We'll send you some extras. Syringe comes like this. This is the larger needle injection to be used for mixing. And if someone will be giving you this medication, they'll be administering it into your buttocks, and that will be, the same needle will be used for that. It's a longer needle because muscles are deeper into your body compared to the smaller needle injections, which are just going into the subcutaneous tissue. So I'm going to uncap my syringe, and the only thing that's confusing and noteworthy is even though we send you this Hcg in powder form and your diluent bottle, there's 10 cc's of diluent in this bottle. Believe it or not, you're only going to use 1 cc for the purposes of your administration. It's confusing, and it's probably the only place that donors sometimes make mistakes. So we'll be repeating it to you as we give you instructions during the cycle from your cycle team nurse. But it's only 1 cc. This syringe holds 3 cc's. So you'll be coming back to the 1 cc mark, which is here at the top. Also note, in these 3 cc syringes, the top of the plunger has a dome shape versus the Lupron, which has a flat top to it. You want your medication dose to actually be at the peak of the dome. So we want that dome to be matched up to the top of the dome to be matched up to the 1 cc line. And it's the same principle that you would be using for drawing up the gonal-F and reconstituting. You'll open your diluent. You will clean it off with your alcohol wipe. We'll pretend. You'll be putting some air into the vacuum seal container. You'll be flipping over, slowly withdrawing back to your 1 cc. Again, you can go past the 1 cc if you'd like, and then push back up to 1. Taking your needle out of your bottle. Got to give a pretty good flick to get rid of the air bubbles. If that doesn't work, and you say, oh no, there's an air bubble and I'm worried, even though you don't have to be worried, you can tap on the side of a table without contaminating your needle, and that will force that air bubble to go up and out. Now I'm injecting that, after I've done my alcohol wipe, into my Hcg powder. Give it a little swirl. It will reconstitute very, very quickly. Over I go, and I'm pulling back my 1 cc. And it's the same principle. Now, most of our donors do not have someone to give them an intramuscular injection in their buttocks. Most of our donors don't. So what we do, and you can let us know if you're going to be one of those donors, is we will send you some extra loose needles. There'll be 3 of them in your packet, which are half the size of the intramuscular needle and a little thinner. At this point, after you've drawn up your Hcg, you will be actually opening one of these needles, taking off the needle you use for mixing, and without touching the inside of this needle, putting this on as such. Okay? Then this will be ready to go for you to self-inject. The self-injection of the intramuscular needle is done on the thigh muscle. And I'll be showing you that after, on where to actually do that. The other thing that's noteworthy about Hcg is that you can only reconstitute it right before you're going to be administering it. So you can't reconstitute it at 6 in the evening and then give it to yourself at 9 in the evening. You're going to reconstitute it right before you're giving your dose to yourself. Very important because it has a short life of being able to sustain itself in the bottle. So it really affects the potency of it. So that's an important thing to note. The other important thing to note about Hcg is that you will be given a time to self-administer your Hcg starting anywhere from 9 p.m. until 2 a.m. Sounds kind of crazy, but what we're doing is we're lining you up with all the other people that will be retrieved 36 hours later. And we stagger the times of retrieval by about 45 minutes. So it's extremely important for you to take your dose exactly when you're supposed to take it. You may be told 8:45 at night. You may be told 12:15 in the morning. Very important to follow that time. If for some reason something happens and you have an emergency in your life, you take your Hcg, but you have to take it, let's say, 2 hours after your time that you were given by your cycle team nurse, I want you to call the doctor on call and let them know the exact time that you gave that dose. It's going to be important. The reason being that you could possibly prematurely ovulate all the eggs that have been created in the cycle and thus lose the cycle. And we wouldn't want that to happen for you or for your recipient. So it's important to let us know if something did come up and you can't take it exactly at the time you were supposed to take it. Okay, we talked about FDA guidelines. Post-retrieval therapy. The medication for post-retrieval is the antibiotic that I referred to earlier called doxycycline. If you have any allergies to medications, particularly any antibiotics, please let us know today. We'll be sure to order something that's just right for you. The antibiotics will be started, you'll be advised to start that the evening of the retrieval, so after you go home. I want you to take that medication as instructed until all your pills are gone. Don't just take it that evening. You're going to be taking it for about 24 hours, and I want you to keep taking them until all the pills are gone. Monitoring, very, very important. When you're taking these medications and you're in cycle, you need to be monitored very, very closely. with blood work and vaginal ultrasounds. Pretty much every time as donors, every time you come in, you'll be having both a blood draw and a vaginal ultrasound, except for your baseline testing. At baseline testing, you'll be having blood work only. The vaginal ultrasound will check the size and the number of the follicles, do actual measurements of it, and the blood test is for either estradiol alone or estradiol and progesterone. When are you doing your monitoring? During the weekdays, you'll be coming in here to the Brigham or to one of the satellite facilities, which we can talk about when we meet individually. You're going to L1, which is lower than the lobby level, in the ultrasound department between 7 and 8 a.m. for ultrasound and blood work. If you only need to have blood work drawn, then you'll be coming in to the third floor lab, which is down the hall from the Center for Reproductive Medicine, and that is between 7 and 9 a.m. Weekends, a little different. The timing is 7:30 to 8:30 a.m., always done down in the ultrasound department on L1. That would be for blood work and ultrasound, or one or the other. Little word about satellite facilities. We do have 4 satellite facilities. If you choose to go to a satellite facility because it'll be more convenient on your way to work or school, it's fine, but there are a couple of extra steps that you need to take. The satellites they're associated with different hospitals, so you do have to register at each of the satellites once before you begin. And the satellite will be happy to give you instructions on how to do that. You can either do that by phone or you can do that in person. They'll be giving you a hospital card similar to your blue hospital card here, so you'll have a medical record number at that facility as well. So we have one at North Shore Women's Health Center in Danvers, one in Exeter, New Hampshire, also Stratham area, and also at Newton Wellesley Hospital, one of our more popular satellites. 850 Boylston is actually an offshoot of the Brigham, just another one of our buildings out on Route 9. Very convenient, but you can only use that on weekdays, not on weekends. So if you do choose to go to 850 Boylston, on weekends, you'll just come here instead of going to 850. The lab slips in your packet that I went over at the beginning for vaginal ultrasounds and for blood work, those can actually be used at 850 Boylston and here at the Brigham. The other facilities, your cycle team nurse will be faxing an order every time you need to go for testing there. So our lab slips are not good at the other satellites. So you'll tell us today if you want to do a satellite, you'll register there, and you'll have to actually set up an appointment at the satellites each time you're going to test. Most of the satellites begin testing at 7:30 in the morning and offer you appointments every 20 minutes. Official sign-in sheet. In your packet, there's an example of that official sign-in sheet that I actually showed you earlier. Very important to fill that out. Please leave us exact numbers and in the order of the priority of how you'd like to reach you in the afternoon. It's most important that you receive your call back from your nurse as a live call. The reason being that if you have a message from your team nurse telling you to adjust your medication for that night, if you have questions and try to reach back to your nurse by calling her, she may be gone for the day, she may be calling other patients. You're going to have trouble reaching her live sometimes just because of the busyness of the unit. So it's really best if you can answer your phone live. So a cell phone that you can pick up live between 2 in the afternoon and 5:30 in the afternoon every time you test is going to be something that's very important. Monitoring. When you do come in for testing in the morning, we'll be looking for your results. The nurse, your cycle team nurse, will round with your doctor by 2 o'clock and will call you with new orders by 5:30. If for some reason your nurse misses you or you don't hear from her or you have a question and it hasn't been answered, 5:30, from that point on, you would need to call the IVF doctor on call. Pre-op appointment. At some point in your cycle, we'll be asking you to have a preoperative appointment for your egg retrieval. At this appointment, you'll be meeting with one of our reproductive endocrine doctors and an anesthesiologist to sign consents and review your procedure. If you're testing here at the Brigham, we'll schedule that appointment for one of the days that you're coming in for your monitoring anyhow. If you are a satellite patient, that will be an additional day that you'll have to come in because only this appointment can be accomplished here at the Brigham. It takes roughly between 20 and 40 minutes to meet with these two physicians. Egg retrieval. Let's talk a little bit about that. We do our egg retrievals in the main tower of the hospital here at the Brigham, in the Center for Assisted Reproduction. It's also known as the CAR Center, C-A-R. We'll ask you to have nothing to eat or drink before midnight, the night before your egg retrieval, and to arrive with your blue hospital card in hand. You're going to arrive 1 hour before your egg retrieval. We're going to admit you to a preoperative area, which is actually the same area that you'll recover after your procedure. You're going to change into a hospital gown. We're going to start an IV. We're going to go over things with you. You'll have your own nurse that day who will admit you and recover you as well. And you may bring a support person with you who can be with you both before the procedure and after the procedure. Excuse me. Okay, now you're ready. You're ready to go back for your egg retrieval. The anesthesiologist will have given you a little bit of IV sedation to make you comfortable and reduce your anxiety. We have only one operating suite for this procedure, so each patient goes one at a time. Anesthesia, you'll be offered either general anesthesia or spinal anesthesia. Most of my donors do pick general anesthesia. It's a great sleep, you're relaxed, you're comfortable, but your anesthesiologist will talk to you about all your options. We'll place your feet up in stirrups, just as the same as when you have a pap smear. And we'll be doing the procedure under ultrasound guidance. Excuse me. The ultrasound, vaginal ultrasound probe will be inserted into your vagina, and then we'll be sliding a long tube, very small little tube, next to the ultrasound probe. And inside of that tube is actually a needle that we will use to insert into each follicle, again, the fluid-filled sac that contains the egg or eggs. We'll then aspirate out, suck out those eggs, and that fluid will be removed, and we'll be passing that fluid to the embryologist who will be in the room. Actually, the embryologist will also introduce themselves to you. They'll be checking your tag to verify that you are who you are, and there's a lot of identification that goes on in this process. We're pretty strict on those guidelines. The fluid will be passed to the embryologist who will take that fluid, bring it to the lab. Your recipient's partner will be producing a sperm specimen that day. They will be taking the sperm and combining it with the eggs in the lab. And that's pretty much where the magic of our embryology department begins. I also want to tell you something else about the Center for Assisted Reproduction. It's very important that when you arrive that you do not use any agents that would be toxic to the eggs. It's a very careful, sterile environment. What does that mean? We would ask you to not use hairspray, body gels, perfumes, anything that would be could be considered toxic. I know it doesn't seem like they could be that toxic, but it is important for the eggs. We'll also ask you if you wear contact lenses to choose to not wear them that day and wear your glasses, please. No jewelry, no nail polish. Remove if you have any nasal piercings or tongue piercings, we'd ask you to remove those and leave those home as well. Okay, post-operatively. Your egg retrieval, believe it or not, only takes about 20 minutes. It's pretty quick. And then you'll recover for about 1 to 2 hours after the actual egg retrieval. We'll offer you something to drink. We'll help you to the bathroom, allow you to wake up from the anesthesia a bit. We do plan to retrieve our donors first thing in the morning. So we're looking to retrieve donors somewhere between the 9 a.m. and 11 a.m. window. We do this because we want our donors to have extra time to recover and be very comfortable before you go home. It is extremely important that you plan for someone to be with you for discharge. We cannot discharge you if you don't have someone with you. After all, we've given you anesthesia, and we don't want you to go, sort of loping out into the street and being by yourself. So you're not going to drive. You're not going to take the bus alone, okay? You're not going to take a taxi. Someone must be here for us to let you go home. If you don't have someone to be with you, then your recruiter can actually hire a medical escort. They're not a nurse or a physician or a medical assistant per se, but there's someone that can be with you as you go home to your hotel, to stay with you for a few hours, get you something to eat, make sure you're comfortable. So if you don't have anybody, or you're not sharing this with too many people, or your friends are working and it wouldn't be convenient for them, please let your recruiter know, and they're happy to set up a medical escort for you. You may feel groggy initially in those first 1 to 2 hours when you're still with us, a little sore, a little crampy, maybe a bit of a backache from being on the operating table. We'll be giving you discharge instructions. We'll be giving you a prescription for pain medication. You may want to take advantage of that pain medication for the first at least 24 hours, because you may cramping for some people is a lot, and for some people it's a little, really very individualized. Big important thing to know, you must recline when you go home from your egg retrieval. No going out, no partying, no dancing, nothing that day. It's a day out of your life. You have to go home, you have to lie on the couch with a good book, a magazine, or a video, okay? DVD, I guess I should get in the year 2000. Anyhow, you have to lie down. You can really get into some serious complications if you go out and run around and the next day start your jogging back up or rollerblading. You don't want to do that, trust me, okay? You're also going to start that oral antibiotic that night. Don't forget to do that and to finish that prescription until it's done. If you are flying home, if you're coming from out of state, we would rather that you fly the evening of the day after retrieval. We want you to be in town if you wake up the day after your retrieval and you don't feel well and you're not sure or whatever. We want to bring you in. We want to examine you. We want to be able to take care of you. We don't want you off somewhere. Okay, so that's important. And, you know, the usual taking it easy for 48 hours, very important. Disposition of your eggs and embryos. Important for you to know that once the eggs are retrieved, they're no longer your property. They actually become logged in under your recipient's medical record number. So not that any of you want these eggs, but you do need to know that once the eggs leave your body, you no longer have a say as to what occurs with them. Well, what does that mean? Your recipient, what we will be doing a few days after your egg retrieval is we will be putting the embryos, probably the 2 best embryos, back into your recipient upon embryo transfer. If all goes very, very well, there'll be enough good quality eggs, embryos, to cryopreserve or to freeze. Basically, what that means is that we'll be able to store those embryos. So if your recipient does become pregnant and has a child, she can come back in a few years and thaw the embryos that are left over and conceivably have a child of the same genetic material. Also, if your recipient just doesn't become pregnant on this fresh egg donation cycle, she can also come back and have another attempt at pregnancy, or if she has a miscarriage in that unfortunate situation. Unusable embryos, abnormal embryos, are disposed of as are all our medical waste. Emergencies. Anywhere along the line, even though we're closed in the evening and on weekends we're here on a limited basis, if you have an emergency, if you have a question or a concern, you are free to call our physician on call. Our physicians on call have a very specific name. They're called an F&E Fellow. It stands for Fertility and Endocrine Fellow. These are physicians that practice in this subspecialty. You can reach them at 617-732-4222, our main number for our unit, and you'll follow the cue. You press number 1, which will put you in touch to our page operator who can page the fellow. But you'll need to be able to tell them the lingo of F&E Fellow on call. You're going to want to stay on the line when you page the physician, or leave a callback number and the physician will call you back. And be there when the physician calls you back, okay? So they're not worrying about you. Additional information, rarely cycles are canceled for whatever reason. A couple of the more common reasons would be that for some strange reason you don't respond well to the medications. We're giving you the medications, but excuse me, you're not stimulating adequately. Another reason for cancellation would be that your estrogen level, as it rises in your blood, does not match the number of follicles that your ovaries are creating. This would mean something is not quite right. Nothing dangerous to you, but something is just not quite right for the actual cycle. If you miss testing, or if you miss taking a dose of medication, really important to not miss your medication. If you just say, hey, I'm going to skip my dose today, I've got this great party I'm going to, and I'm not going to be home between 6 and 9 p.m., and I'm not going to take my medication, your levels of estrogen are going to plummet. This is not the type of thing that you can just skip. Unfortunately, if you skip a dose, you lose the cycle because your levels really fall quickly, and you can't sort of get them back up by just starting up the next day. It's not the way these particular medications work. Ovulation before egg retrieval. Very rarely a donor will ovulate before the egg retrieval. That mostly speaks to the timing of that trigger medication, the Hcg medication. So hopefully if you just follow the instructions, we'll walk you right through it. That won't happen. And rarely there's no fertilization, which can be an egg issue or a sperm issue. Again, possible complications. We talked before about OHSS. Infection at the injection or operation site. The injection site could be the site of where you're giving the medications. It may be a very small local redness might occur, very rare. Rarely an infection at the operation site, that is where the follicles are removed. Extremely rare is something called ovarian torsion or twisting of the ovaries. The ovaries become very heavy from the medication. This actually mostly happens with our older patients who are going through this process themselves and using their own eggs and their own uterus. Medication side effects we talked a bit about, feeling moody, feeling some sadness, and there are always surgical risks to every surgical procedure, even one that's as short time-wise, only about 20 minutes, but there's always a side effect that could occur. Infection, bleeding. These are the two big side effects. I'd like to say that we take a lot of precautions, and really most of our donors don't have complications. Bear with us, because we're going to be watching you very closely to avoid such matters. Okay, that's all for your own health. Pharmacy information. We'll be faxing orders to a pharmacy, a special mail order pharmacy that is specific to fertility medications. We will be mailing the order to them. Your recipient will be arranging for payment of the medications, and then the pharmacy will be in touch with you to arrange the delivery of the medications. Excuse me. The medications, it's really important that the medications are delivered to a human being. It doesn't have to be you. It could be a friend, it could be a family member, or you can have them delivered to your job, or you can have them delivered on a weekend, on a Saturday. The reason it's important that you actually receive the medications, or another human, is because these medications are very, very expensive. They cost anywhere between $2,000 and $3,000 for the box of medications that you'll be receiving. So you can imagine it's very important that they're not left out in the heat or cold or any of the elements. And they are non-returnable. So it's not like you can send them back and get a new batch. It doesn't work that way, okay? So that's an important thing to remember. Typical cycle, you're calling with your period. We're getting you started on birth control pills between day 1 and 3 of your period. You're going to start those pills. You're also going to start your barrier contraception. Remember, abstinence, or if you need to, you'll be using condoms. Then we'll be starting you on your further suppression therapy, which is the Lupron, the small needle injection you take between 5 and 7 in the morning. Then we'll be giving you a point in time where you'll be stopping your birth control pills but continuing on Lupron and coming in for your baseline ultrasound, blood work, and your blood draw. Then you'll be starting your stimulation medications, either the Gonalef or Falston, or in more rare cases, the Repronex. And you will be then be given your very specific time for your trigger medication, the Hcg. That's roughly about 7 to 14 days into the stimulation medication. You'll be taking that Hcg. 36 hours after your Hcg, you'll be having that egg retrieval. Consents. I'd like to just take a moment now to just go over consents, which are in your packet. If you'd all like to open your packet up, we can take those consents out and take a peek at them. All righty, here we go. So, first two consents, you don't have to really be able to see them clearly. They're that one has a yellow back, and it's named audit consent. The other doesn't really have a name, but it begins with data from your ART procedure. These two consents are research consents, and they're used for the bodies that govern us and follow us, namely the Center for Disease Control and the American Fertility Society. They're used for us to be able to look at your chart and look at your recipient's chart and see how well the cycle went. It looks at your age, how you responded to the medications, looks at your recipient's age and whether she became pregnant and how she did, and follows her pregnancy accordingly. We need your permission for these two governing bodies to be able to look at your chart. They don't share your name with any other place. It's simply for statistical gathering. So that's what these two consents are. We'd love if you'd sign them, but you're not bound to signing them, so don't feel obliged. Most people are pretty comfortable, though. Next consent is your Lupron Consent. This is just consenting to the use of Lupron, and it goes over the fact that you do need to use condoms when you're on Lupron. The last consent is sort of a large double-page consent, and this is the consent for the actual egg donation process. The name of it is Ovum Donation Consent. This describes everything we've gone over in class today. It talks about all your testing and your monitoring and everything that we're doing. And by signing this consent basically means that you agree to go through with the procedures. What I'd like you to do is sign these consents today, and either myself or my colleague Nancy or one of the other nurses will witness these consents for you. We can take care of that. One note, if you are a known donor, if you are a sister or a cousin or a friend of your recipient, and you are married, we will require the signature of your husband on this. I know it's kind of, goes against our feminist ways, but we do require a husband's signature if you are married. And actually that goes for anonymous donors too. Okay, so that covers our consents. Okay, important takeaway messages. Everything begins with your period. So after today, it's going to take about 2 weeks to process all your lab tests and everything that went on today. Mostly it's your pap smear that takes a while to come back after today. If you feel like you're out there and you're hanging and you're waiting, just remember, every time you get a period, call us and let us know. We're either going to be putting you on birth control pills at that point or getting you ready and getting you started up for your Lupron start. Big takeaway message, abstinence from intercourse is desired. However, if desire is too great, condoms. Okay, I think you've heard that from me enough. We would hope that all you young ladies are using condoms anyhow. I would like to just go over one thing that I can recollect that I did omit when I was speaking about medications. In your books, you're going to notice different sites to take your medications. The site for subcutaneous or small needle injections, the site of choice, is actually your abdomen. It seems like a sensitive place, but that's where most donors are really comfortable giving their medications. You want to avoid the area right around your belly button, but you're going to be using the rest of your abdomen for that. You can also use the top of your thigh for a small needle injection or the back portion of your upper arm. And remember, the intramuscular injection, we're going to talk about whether it's going to be someone else giving that to you in your buttocks or you'll be using your thigh muscle for that. And we'll go over that when we meet with you individually. All right, I'll go back to that a second. Thank you for your attention. We look forward to your questions. I know it's a lot of content, a lot of information, but we'll be meeting with you after to go over everything. Thank you.